as far as optimizing conventional chemotherapy for ALL, we have really, as far as using conventional chemotherapy, we have almost reached the maximum tolerability for most patients. The kind of major moves forward in the field have been the use of pediatric chemotherapy regimens, which tend to be more intense than adult regimens, but also less myelosuppressive. But moving them into older patients, generally in the age 16 to, so adolescent, young adult, which is loosely defined as 16 to 39. The CALGB 10403 study applied the AALL0232 regimen, which is a pediatric regimen, to the adolescent young adult population. They had a 60% event-free survival at 3 years, which is very similar to other studies using these pediatric or pediatric-inspired regimens in adolescents and young adults. So each of these regimens is fairly toxic, even in younger patients, and a lot of patients end up not completing therapy because of toxicity. Even with that, the long-term survival is excellent. So the future, because we have kind of probably reached the maximum benefit we can get from chemotherapy across age groups at this point, without, that is, we found the kind of balance between toxicity and efficacy of the treatment. It's really new agents that don't add a whole lot of toxicity, but may increase efficacy that I think will change conventional chemotherapy. I'll also say if some of these chemotherapy-free regimens show outcomes similar or better than conventional chemotherapy, then we may be doing studies to try to get rid of conventional chemotherapy, given the short-term and long-term toxicities. It's not just potential death from infection and other complications of therapy with conventional chemotherapy. There are also long-term complications, such as osteonecrosis of the bone, which can require joint replacement in young patients, secondary cancers, bone marrow cancers, and sarcomas, as well as a number of other neurologic and neuropsychiatric long-term complications. So really the future of conventional chemotherapy, I think, is going to be the rational and safe addition of targeted therapies, such as Inotuzumab, Ozogamicin, which I described, and it's being studied in the front line in the Alliance 04-1501 study, which basically uses that 10403 chemotherapy backbone and has Inotuzumab, Ozogamicin as a block of therapy on its own, to not add toxicity to the backbone chemotherapy, but still take advantage of the high efficacy of the drug. Other studies, such as ECOG 1910, are looking at Blinatumomab in consolidation with conventional chemotherapy. So the current study and then future planned and ongoing studies are also looking at drugs like Venetoclax, which can synergize with chemotherapy to help with leukemia cell killing and potentially increase cure rates. So it's really the revolution in targeted therapies that's going to change therapy, given that we've kind of reached this limit of cytotoxic chemotherapy for our patients. And it should also be said that when we're talking about drugs like Inotuzumab, Ozogamicin, and Blinatumomab, these are actually two of the most active single agents we have for ALL, and they're very new. So the potential for dramatically increasing cure rates is there, and we look forward to the results of those studies.